Okay, I hope I'm not taking too long. Zahara, please keep me appraised if presenters join. I have 30 minutes to finish this part. So what are the manifestations of lung cancer? How does lung cancer present? I have tried to divide this into 3 groups. There are those problems which happen if the cancer is restricted to the intrathoracic area, to the chest. There are those ones when it has gone out of the chest, but there's also a third group which we call paraneoplastic syndromes, which I will explain. So in the chest, the commonest is cough, which occurs in about 50 to 75% of the patients. It is most common in squamous cell and small cell. If I can remind you, the 4 types: small cell, which is a group of its own, squamous, adeno, large cell. The reason it is so common in squamous and small cell, because these tumors are more central and the cough is mostly coming from obstruction of the airways and the irritation. The another one is what we call bronchoria. So bronchoria is when you produce large amounts of white sputum, but it's not like you are coughing. The sputum is just coming. And if you've been in the clinic, you've seen patients like this. So I'm not coughing, but the mucus is just coming. And this is very characteristic of adenocarcinoma. Okay? So these are a few parts. But as I will conclude, you will see these symptoms occur in almost other respiratory diseases. Now, the second one is chest pain. Up to 40% of patients have chest pain. And this is quite obvious. If a tumor grows and it touches on organs of the lung which have nerve pain receptors. I think I will first take a break there. We learned in physiology and anatomy that actually the main lung tissue has no pain receptors. So that's why lung masses can grow very big when the patients have no symptoms. If you are lucky, if the mass starts growing towards tissues which have nerve pain receptors like the pleura, like they are central, and you get obstructive syndromes, then it is okay. But if it grows somewhere in the middle where there are no pain receptors, it will grow and become big, and then by the time it is detected very late. Pain can also come if cancer is associated with thrombosis. As I will tell you, lung cancer has a paraneoplastic syndrome which causes hypercoagulability. So if you develop clots within the pulmonary vessels, you will get chest pain. As you investigate the pulmonary embolism or clot, then we land on lung cancer. The third commonest symptom also occurs in 40%, and I will show you what we have found in our screening, is dyspnea. And of course, this occurs mainly if the cancer has intrabronchial spread, then you will get dyspnea. However, because lung masses are growing in the lung, which is 70% air, you are likely to get atelectasis. If a mass is compressing on an airway, the lung will collapse. And if it collapses, it tags onto the pleura, then you will get chest pain. Then you can get pneumothorax, or you will have pleural effusion, pericardial effusion, and then you will have dyspnea. I have put pleural effusion in red here because it has been actually one of the key presenting symptoms of lung cancer in our patients here in Uganda, surprisingly. When we started screening, we thought it was going to be mainly the huge masses, but what we are finding is that people are coming with effusion. If you just tap a little and find it is exudating, start giving treatment, you miss the point. Actually, now on our pulmonary old standard of care, you come with a large effusion, we drain it and repeat imaging. In most cases, after that, the mass will now be visible after the compressed lung has expanded. I think this one I had not seen in the textbook. We have just learned on the bedside. Those are the intrathoracic manifestations. There are other intrathoracic manifestations which I will quickly go over. They are not so big. Hemoptysis, hoarseness of the voice, when especially the Panicott's tumor, when there is obstruction of the nerves, wheezing. Wheezing, when it occurs in lung cancer, it is mainly not the wheezing of asthma and COPD, which is widespread on the chest. Here you will find a patient who has a wheeze in a particular part of an auscultate area on the lung, or I mean on the chest, meaning that the obstruction on the airways in that area alone, and now the patient wheezes only in that small area. So if you are the kind of doctor who is not following the pattern, you will miss this wheeze, and it could be the only sign of lung cancer. Panicott's tumor, which is a syndrome liked by students, is lung cancer rising in the superior sulcus of the lung, basically up here. And of course, because of its position, there will be shoulder pain, there will be Horner's syndrome, and then the hoarseness of the voice and others. I hope I'm not taking too long, but I think these symptoms are important to go through. Then we have extrathoracic manifestation. These ones will go quickly. Lung cancer can spread almost any part of the body, but the signs will depend on the organ affected. For example, in the bone, you will have pain and pathological fractures. In the adrenals, you will have issues with the electrolyte balance, blood pressure control, although this is very rare. In the brain, you will have the symptoms of a space-occupying lesion in the brain. And now we have the paraneoplastic syndromes, which I told you about. These paraneops are tumor effects that are not related to the direct invasion of the tumor, or obstruction or metastasis. There is no metastasis in that system. It is paraneoplastic. The commonest ones are things like hypercalcemia, hematological manifestations like anemia, leukocytosis, Cushing syndrome, and others as they are listed there. So as you can see, the evaluation of a lung cancer patient should be comprehensive. I think now I will be able to move faster. So how common are lung cancer symptoms? I have already given you the percentages, and I think I will just let this go. I will show you data from our patients. So therefore, what's the role of this clinical evaluation? Which is the major topic. How can clinical evaluation or good clinical acumen help us in early detection of lung cancer? We note that lung cancer symptoms overlap with many other lung cancer, other respiratory diseases. And we also note that by the time of clinical manifestations, I think as Margaret will tell you, lung cancer is advanced. And as I have explained, because if the cancer is growing in the middle somewhere and it has not touched the pleura, it has not touched the bronchus, the pain nerve endings are very few in the lung, it will just grow. And meanwhile, it will be sending metastasis. However, clinically, you can suspect lung cancer if patients have persistent symptoms that are negative. I'm speaking for Africa and Uganda, for most common infections such as TB. Someone has a cough which has not gone, you've tested for TB, it is not there. Please suspect lung cancer and order for at least a chest X-ray. And should you see a nodule or a mass, refer that patient for further evaluation. This is actually what we need to do to improve early cancer detection. Everyone who has persistent symptoms, which are not TB or asthma and COPD, and is not responding to treatment, just order an X-ray. And should the radiograph or radiologist also see a nodule, a mass, ask for help. Suspect lung cancer in people with risk factors. But as I've told you, the commonest, which is smoking, is very rare here. If you take the issue of biomass, the issue of dust from roads, we are all exposed. Okay? But most importantly, always suspect and rule out lung cancer in all patients with respiratory symptoms which are persistent. I think that's the key message that I will leave here. What do we do as doctors? If something has not entered your differential diagnosis, the pre-assessment differential diagnosis, there are two as a differential diagnosis. The gut feeling when the patient has told you very little and is walking in. If you don't think lung cancer could be on the list, it will not be the things you are going to, the questions you are going to ask. You will find you have not even asked for smoking, by the way. You have jumped to pneumonia. So make sure lung cancer is on your pre-assessment differential diagnosis of a patient with persistent respiratory symptoms. And the rest will flow. As we hear from the Cancer Institute, systems have been put in place to help to do the detailed evaluation. So now, what have we seen in the 3 years we've been screening for lung cancer in this project called the Uganda, Tanzania, Cleveland HIV-associated lung cancer project? This project, like I said, started in 2019. And these are the partners. As you can see, these are the very many people. It's a U54 mechanism, so it's a very large project, which also includes awarding of fellowships. And so far we have awarded, I think, up to 10 fellowships. We will award 4 each year. And I think you can recognize many faces on this, but that's the important thing. The important thing that we need to understand the epidemiology of lung cancer in Africa and its relationship with HIV. We need to understand the driver mutations. We also need to develop AI algorithms to be able to diagnose, to differentiate lung cancer nodules from TB nodules, because that's our biggest problem in our setting. And this is our screening algorithm. When people suspect lung cancer at cancer centers, the ones who have gone to cancer center thinking they have lung cancer, we do tissue. However, we have established a network to pick up nodules and masses, like I told you, at all CT and X-ray centers across the 2 countries. And as you will see, we are now detecting cancer faster. What's the progress? So far, we have screened 268 patients, and we have enrolled, confirmed, 114. This does not mean these are the only cancers, because each study has inclusion and exclusion criteria. Some people don't consent, other people die before they are enrolled, but at least we have been able to screen people who look like lung cancer, 268. The median age is 60. I think you remember from Dr. Chibulde's study, the median age was, I think, 56. Majority of the patients are females. This is also a key finding, because in the rest of the world, majority of lung cancer is men. You can see only 21 are smokers, 28% are smokers, okay? And then majority are adenocarcinoma. Remember, it is 67.4. This is now in the current study. If you compare to retrospective, it was 71. Here we are finding 67. And of course, stage 4 is slightly lower. 86, I think, because of active case finding. Remember there it was 92%. And then, I think, let me take you to this. Oh, I wanted to show you the mortality rate. These are the outcomes that we come back. You can see the people who have died, 45.3%, very high mortality. And then I will now take you to the symptoms, because I told you I'm going to show you in these 114 patients. I think this is only Ugandan data. Yeah. I think Ugandan data only. Irene will comment, she's on the call. But you can see here, our main presentation is breathlessness. Then we have general tiredness, which is non-specific. You can see cough is still the commonest, 79. Breathlessness, chronic dyspnea, 57. Shortness of breath, 51. That is just terminology. And then chest pain is very common. And as I told you, most of the patients are presenting with pleural effusion. This is the histological classification. If you remember, adenocarcinoma is still the commonest, squamous, and then large cell is only 5%. Almost what I showed you earlier. And this I've already shown you. What has been our experience that people present late, of course, and then people cannot afford screening or diagnostic tests for lung cancer, CT scans, biopsies, they cannot afford. And what have we been able to do? We have been able to leverage the project to pay for the CT scans and the biopsies. But still, we need to figure out cheaper ways of detecting lung cancer. And I think that's where Dr. Kuku's presentation of liquid biopsies, biomarkers may be handy. I think I will stop there. I want to thank you very much for listening to me.